Roughly 1 in 5 people worldwide carries a hidden cardiovascular risk factor that a standard cholesterol test often misses. It's called lipoprotein A, pronounced lipoprotein a or LPA. It was discovered back in 1963, yet many people have never heard of it, and most have never been tested. That matters because if your LPA is high, your risk of heart and blood vessel disease can be higher even when your usual cholesterol numbers look perfectly normal. So what exactly is LPA? To understand it, start with a lipoprotein. A lipoprotein is a particle that carries fats, including cholesterol, through your bloodstream. The most familiar one is LDL, often called bad cholesterol. LDL has a core of cholesterol and fats wrapped in a protein shell called apolipoprotein B. LPA looks very similar to LDL, but with one critical difference. Attached to the LDL-like particle is an extra protein called apolipoprotein A, or ApoA. You can think of LDL as the main body and ApoA as a unique tail added on. That tail is what makes LPA different and more dangerous. Here's a key point. LPA levels are mostly genetic. About 80 to 90% of your level is determined by your genes, set early in life and relatively stable over time. Diet, exercise, and weight loss are excellent for overall heart health, but they usually don't change LPA very much. The only way to know your level is with a specific blood test. When LPA is elevated, it affects the cardiovascular system in 3 major ways. First, it's atherogenic. Like LDL, LPA can deposit cholesterol into the walls of arteries, speeding up a process called atherosclerosis, where plaque builds up and narrows blood vessels. Second, it's prothrombotic, meaning it increases the tendency for blood clots to form. The ApoA portion of LPA looks similar to plasminogen, a protein involved in breaking down clots. Because of that resemblance, LPA can interfere with normal clot-dissolving processes, making clots more likely to persist. Third, it's pro-inflammatory. LPA carries oxidized phospholipids, which are irritating molecules that trigger inflammation inside blood vessel walls. This inflammation makes plaques more active and unstable. Together, this triple effect helps explain why high LPA independently raises the risk of heart attack, stroke, peripheral artery disease, and aortic valve stenosis, which is a narrowing of the heart's main outflow valve. Measuring LPA is straightforward. It's a simple blood test, usually reported in milligrams per deciliter or nanomoles per liter. While units vary, levels above about 50 milligrams per deciliter or 125 nanomoles per liter are generally considered elevated. What makes LPA especially important is that it's an independent risk factor. That means it adds risk on top of LDL cholesterol, blood pressure, smoking, and diabetes. Because of this, major medical organizations now recommend at least one lifetime LPA measurement for adults. Testing is particularly important if you have a family history of early heart disease or unexplained cardiovascular problems. As for treatment, standard statins are excellent for lowering LDL, but they don't significantly lower LPA. Today, management focuses on aggressively controlling all other risk factors to offset the added risk. The good news is that new therapies designed specifically to lower LPA, such as pelacarsen and olpasiran, are in late-stage clinical trials and may become available in the coming years. LPA is a risk factor you can't feel and you usually can't see on routine labs, but knowing your number once in your lifetime can change how you and your doctor approach heart disease prevention. If you have a family history of early cardiovascular disease, don't guess. Talk to your doctor about getting your LPA tested. It's a one-time test that could change your future.